minutes, ask you the questions. So let us know how you are going to present the detailed history of this patient. Okay, one of you can present. And also in the exam, the practical exam, you can read whatever you have written. You need not have to, talk without looking at the case sheet. You can definitely read whatever you have written. Okay, right. Start. No, you want the next slide. You don't have the
Yes.
control yet?
Mahal is doing screen sharing.
Yeah.
Sir.
Mahal is having the control.
Yes, sir.
Mahal, can you just
Is it coming? Is it
move
displaying?
the no, your PPT is displayed, but it has to be moved. The first slide, second slide. Now we'll have to go for second slide.
Is it coming now?
No, it is there on the screen. Your PPT, that PPT is there on the screen, but only the thing is that it's not moving.
Is it moving now?
Not moving, Mahal. How about on your screens, Dr. Geeta?
No, sir, not able to. No, sir.
Not moving. Yeah, now it's there. Yeah, okay. Okay, fine.
Chief complaints. Yes, sir. Can you start, sir?
Read.
Yes, sir. 60 years old male, Mr. Muniappan from Pondicherry, who is a daily wage worker by occupation, came with the chief complaints of right inguinal swelling for the past 2 months, abdomen distension for the past 2 months. History of presenting illness. The patient was apparently normal before 2 months, after which he developed right inguinal swelling. Single swelling initially appeared in the right inguinal region above the groin crease, which extended into the scrotum. Initially small in size, 2 cross 2 centimeters, as described by the patient in hand gestures, gradually increased to the present size of 10 cross 4 centimeters, which increases in size with cough, straining, and lifting of weights, disappears on lying down posture, not associated with pain over swelling or abdomen pain. No history of fever, no history of constipation, vomiting, no history of chronic cough. Next slide. History of yellowish discoloration of the eyes present, history of easy fatigability present, no history of blood transfusion, no history of IV drug abuse or tattooing, no history of altered sensorium, no history of decreased urine output, no history of dyspnea, palpitations, chest pain, or seizures. He has a MET score of 4 to 7. He has a previous history of hospitalization with complaints of severe abdomen distension 1 month ago and was diagnosed as decompensated liver disease. No history of, not a known case of hypertension, tuberculosis, type 2 diabetes mellitus, asthma, epilepsy, or IHT. No history of any previous surgeries. No history of similar complaints in the past. No history of blood transfusion in the past. No history of any recent travel, tattooing, or any medicine intake. Personal history. He follows a mixed diet. He has decreased appetite. Sleep is adequate and undisturbed. Normal bladder and bowel habits unregular. History of alcohol intake for the past 30 years. Daily intake of 150 to 200 ml of brandy. He has abstinence since 1 month since the last hospital admission. No history of any smoking or tobacco chewing. Next slide. Family history, no similar family history in the family, no history of any gastrointestinal malignancies in the family.
Okay, that ends your exam. This thing, isn't it? History.
Yes.
So one thing you should realize, both Gita Varshini and Harini, is that, the comorbid condition, because he has a comorbid condition of chronic liver disease, isn't it? So that should be in the history of presenting illness only. That should not be a part of past history. Because whatever that is, because what you are presenting, you should always realize it is, you are not trying to, diagnose something when you are presenting these history in, as far as anesthesia long case is concerned. You know that the patient
Okay, sir.
is, posted for some surgery, but you have to find out, whether the patient has any comorbid condition associated with or not. And if the patient is associated with a comorbid condition, you have to find out the severity of the comorbid condition. And that severity of the comorbid condition should be there in the history of presenting illness itself. So you don't keep it to the history of past illness or past history. So here, very important history is, the patient having a chronic liver disease, and that too you have written that in the chief complaints also. Presenting complaints, you have written that the patient has history of, distension of abdomen, isn't it? That you have written. So once you have written that, and also that should be there in the history of presenting illness. So that you have to slightly alter it and write down about ascites to be there in the history of presenting illness, where you say that he was admitted about a month back. The whole thing should be in the history of presenting illness, and he was diagnosed
Yes,
to
sir.
have a, a decompensated chronic liver disease, isn't it? That is what he
Yes.
has been diagnosed with. Now, the other important thing here is when you have written about the patient also gives history of jaundice. So that should also be in the history of presenting illness. I think you have written that in the history of presenting illness or in the history of past illness.
It is. Yes, sir. History of
Presenting
presenting
illness. So
illness, sir.
now, once you have written that the patient has yellowish discoloration, that means the jaundice. So the jaundice can be pre-hepatic, hepatic, or post-hepatic, isn't it? Cause for jaundice. So that you have to try to get whether he has a pre-hepatic jaundice, hepatic jaundice, or post-hepatic jaundice. Now you tell me what are the causes for pre-hepatic jaundice and what history you would be taking for knowing whether the patient has pre-hepatic jaundice or not.
Obstruction. Any
So pre-hepatic, pre-hepatic
recent history of hemolysis.
recent history.
Sir.
Now, what do you mean by pre-hepatic jaundice? That means the liver is not the cause.
Yes,
Pre-hepatic, that means before the liver, isn't it? So that
yes,
means there must be other cause which is producing jaundice. So what are the most common cause of pre-hepatic jaundice? That means there is a rise in bilirubin, isn't it? So the bilirubin is rising.
portal vein thrombosis.
Pardon? No, that is,
Any portal vein.
that portal vein thrombosis will produce portal hypertension
Yes.
and then cirrhosis later.
Yes.
It is not pre-hepatic. I tell you, okay, pre-hepatic jaundice is because of hemolysis. Anywhere hemolysis is occurring, that can increase actually the amount of bilirubin, isn't it? Because, whenever there is hemolysis is occurring, heme is degraded to bilirubin. We'll come to that, the what happens to this heme and bilirubin metabolism also later. So definitely the bilirubin levels will be increased, and once the bilirubin levels are increased, so that will enter into the blood and you get an hyperbilirubinemia. And if it is more than 2 bilirubin, so the sclera will be colored and the patient will present with jaundice. So that is very common. So any bleeding anywhere in the body or because of degradation of RBCs, more degradation like hemolytic anemias, any hemolytic anemia can produce pre-hepatic
Yes,
jaundice.
sir.
One. And anywhere, for example, the patient has had a trauma, has got a fracture, there is a big thrombus. And this thrombus, again, it dissolves. And then that pushes the extra amount of bilirubin into the blood. And that also produces a pre-hepatic jaundice. So that is what is very important, hemolytic jaundice or any trauma. So what history you should be asking about to rule out pre-hepatic jaundice? No, in the history only you have to rule out all these things, whether it is a
And
pre-hepatic, hepatic, or post-hepatic jaundice. What history would be asking? Suppose if it is a hemolytic anemias are there. Can you name some hemolytic anemias?
so, yeah, hereditary spherocytosis.
Spherocytosis, okay, one. Then
Sickle cell anemia.
yeah, sickle cell anemias, okay. Thalassemias, glucose 6-PD deficiency, isn't it? So these are some of the hemolytic anemias can be there, and most common probably sickle cell anemia and sickle cell trait. So how do you, in the history, what questions you will be asking in order to rule out whether it is pre-hepatic or not?
History, easy fatigability.
No, easy fatigability will not be there in hemolytic jaundice unless it is severe anemia is there. So easy fatigability will be there in case of even liver disorders, chronic liver disorders. That is there in this patient. Now, this hemolytic anemias, majority we just mentioned are hereditary, isn't it? And they are present from since birth only.
Family history.
Need not be family history. It starts when the person is in the childhood only. It will be there. The history will be there. The yellowish discoloration of sclera will be there from childhood. Jaundice will be there from childhood. So that history you should always take, whether this yellowish discoloration started recently or it was there since childhood. So you have to rule out hemolytic anemias. So the second thing I told you that there can be trauma and there can be a big hematoma getting absorbed into the blood and increasing the bilirubin levels. So any history of recent trauma about you can ask since how long patient is having yellowish discoloration, and if there is history of trauma, a fracture, and definitely it can be the cause for increased amount of bilirubin and jaundice. Many times you must have seen when you have patients with severe injuries, especially multiple fractures and all, when you do a liver function test, invariably the bilirubin will be raised. And we'll come to that, what kind of bilirubin will be raised and all these things. But here in the history itself, it is very important to rule out hemolytic anemia and pre-hepatic jaundice. Okay, another thing which you have to rule out is post-hepatic jaundice. What do you mean by post-hepatic jaundice? Any idea?
Obstruction in the gallbladder, cholecystitis.
Yeah, any obstructive jaundice, any obstruction to the flow of bile from the liver into the intestine.
Common bile duct.
That is what. It can be because of stones, it can be because of malignancy, isn't it? So that can produce obstructive jaundice, which is also called as a surgical jaundice, because majority of these obstructive jaundice, patients are posted for surgery to relieve the obstruction. That is why all obstructive jaundice, which is also called as a post-hepatic, it is not within the liver, it is just beyond the liver, which is called as a post-hepatic jaundice, and also called as a surgical jaundice, can be a cause for jaundice. So how do you differentiate post-hepatic jaundice from hepatic jaundice actually? And pre-hepatic already we discussed. How do you differentiate from the history itself?
Patient will have pruritus, steatorrhea, fatty.
Yeah, very good. Very good. One is pruritus. Now, what is the cause of pruritus in obstructive jaundice?
Bile salts get deposited in the subcutaneous tissue.
Yeah, why bile salts get deposited in the subcutaneous tissue? Why normally they will not get deposited?
The hepatic metabolism of bilirubin to bilirubin metabolism is affected. So
bile salts are different. Don't get confused. Bile salts are different.
Yes, sir.
They are cholic acid and deoxycholic acid. They are synthesized by the liver and secreted in the bile. And whenever there is an obstruction of the flow of bile into the intestines, now these bile salts will come back into the blood. Their amount of content in the blood will increase. So they start getting deposited in the skin. That produces intense itching, pruritus. And that history should be taken, actually, whether patient has itching or not. So to rule out the post-hepatic jaundice. And when will be the itching, the maximum intensity is very high?
After a fatty meal
No, it will
at
be there
night.
in the night.
At night.
Night, daytime he'll get distracted. Night, there won't be anybody to distract him. So he'll start scratching his skin and the pruritus will increase and he'll have a lot of problem with intense itching. So this deposition of the bile salts will produce this itching. So this is because nowhere in your history you have taken that history of pruritus, isn't it? So that is very important. Another very important history you should take to rule out, obstructive jaundice or post-hepatic jaundice is what?
Abdomen pain will be the same.
No, it is color of the stools.
Exactly.
Color of the stools.
Pale color.
Color of the stools. What will be the color of the stools?
White, pale color. Pale color.
Yeah, clay colored stool, isn't it? Very pale, whitish.
Yes.
What is the particular pigment which colors the stools? Stercobilinogen and urobilinogen, isn't it? So for that, bile has to enter into the intestines. If there is an obstruction to the flow of bile into the intestine, so there is no bile. No bile means no, urobilinogen and stercobilinogen, and naturally, the color of the stools will be clay colored or pale colored stools. So these two are very important to differentiate whether it is hepatic jaundice or post-hepatic jaundice. If you can rule out pre-hepatic jaundice, if you can rule out post-hepatic jaundice, and the jaundice has to be hepatic jaundice, isn't it? And what are the causes of hepatic jaundice as such? Causes.
Any hepatic toxicity, pre-existing cirrhosis, drug induced.
Okay, it can be because of any drug injuries to the liver.
Infections and hepatitis.
Infection, it can be because of hepatitis, because of the infections, right? It can be because of, effects of alcohol.
Yes,
Or it can be non-alcoholic steatohepatitis, which also can produce cirrhosis and can produce jaundice, isn't it? So there can be multiple causes of the hepatic jaundice. So here you say that because, I don't know whether you have asked about other causes. So probably you are thinking in terms of hepatic jaundice. So here, that is the reason you have asked about blood transfusion. So why did you ask about blood transfusion? Recent history of blood transfusion.
Hepatitis B transfer from.
One is it can produce transfer of the viral infections like hepatitis B and hepatitis C, and also non-A, non-B virus, hepatitis virus also can be transmitted. But nowadays it is not so common, of course, because everybody is tested before transfusion. But another very important thing is blood transfusion. Can it produce pre-hepatic jaundice?
Yes, sir. It causes hemolysis, sir. Again, massive
It is
transfusion.
incompatible blood transfusion, one, or if there is extravascular hemolysis occur because of minor blood group differences, that also can produce, pre-hepatic jaundice. So that is okay. You have written about blood transfusion. Again, tattooing and all those things, probably you are thinking in terms of any transmission of viral infections, isn't it? Especially hepatitis B and hepatitis C. So another thing is you have asked about, you should go into details about the alcohol intake. You have written about alcohol intake. Daily he takes about, you have written that 150 to 200 ml of brandy you have written. Can it produce this amount of alcohol, 150 to 200 ml of alcohol, can it produce cirrhosis of liver? For 30 years, he's taking. When do you call a person as alcoholic?
Daily intake of more than 35 grams
More than
35
grams, no.
grams.
There are few definitions are there. One is the amount of alcohol he takes every day for a particular period of time. It is also you can say whether the patient is alcoholic or not. Second thing is, his mental status. Also, you can, define whether the patient is alcoholic or not, especially when a patient has become addicted to alcohol and he cannot live without alcohol. And he, in spite of knowing that the alcohol is producing negative effects on his life, still he has continued to take alcohol is one of the definitions for patient to be alcoholic. That is one. But again, depending on the amount of alcohol he takes. So if somebody takes more than 80 grams of alcohol for more than 8 years, you can call him as an alcoholic. More than 80 grams of alcohol for more than 8 years, which can produce, which is actually a significant intake of alcohol, which can even lead to cirrhosis of liver.
Yes.
So now you say brandy, he is taking 200 ml of brandy. So how many grams of alcohol he is consuming if he is taking 200 ml of brandy? What is the percentage of alcohol in brandy?
42%, sir.
Hmm?
42%.
It is between 40 to 50%.
Yes.
It is nearly 40 to 50% because you should know about the percentage of alcohol in many of these the alcohol beverages.
Hmm.
Especially, for example, now if somebody is says that he drinks beer. What is the amount of alcohol in beer?
8 to 10%, sir.
No, it's about 7%. You are correct. And there are certain beers which also have double the alcohol percentage, like 14%. Like certain brands are there, like Knockout beer, Kalyani beer, Khajuraho beer. No, because then you will have to ask, you need not have to drink alcohol to know about these things because you have to take a proper history, isn't it? You have to know exactly whether the patient is taking so much of alcohol every day or not. So for that, you have to know each brand, how much of alcohol it has. So like Knockout, Khajuraho, and all those things will contain 14% of alcohol in beer. And the beer, they won't take in small quantities. They take in, mugs or even in, the full bottle. What do you mean by a full bottle of alcohol? How much it contains?
750.
Huh? One full bottle of alcohol. Pardon? It is 720 ml.
750 ml, sir.
One full bottle of alcohol will be 720 ml because you must have heard about one small, one large, all those things, isn't it? Small peg, large peg, 1/4. So
Yes.
one small is 30 ml, actually 1 ounce or 30 ml. One large is 60 ml,
Yes.
and 1/4 is 180 ml, and 4/4 will make one bottle. So many of the, because why you should know is, many of the patients will tell only, I'm drinking 1/4 of the rum or whiskey or brandy or something like that. Or they may take, every day I take 2 large. So unless we know what is meant by 1 large or 1 small or 1/4, so we'll not be able to quantify the amount of alcohol the patient is taking, isn't it? So that is the reason why we should know about. And majority of these brands, like, it can be whiskey, it can be brandy, it can be rum, or it can be vodka. All these things will have nearly 40 to 50% of alcohol. Now, what do you mean by 50% alcohol? Okay, Geeta, what do you mean by 50% alcohol? Means how many grams in 100 ml?
50 grams in 100 ml. 5.
Yeah. So whenever we say so much of percentage, like 50%, it is always mass divided by volume. It is 50 grams in 100 ml.
100 ml.
When I say 2% lidocaine, it is 2 grams in 100 ml. That you should always remember. Not in milligrams, it is always in grams. So 50% alcohol content means 50 grams in 100 ml.
Yes, sir.
So 200 ml means how many grams of alcohol he is consuming?
100.
100
grams he is consuming. So with our definition, quantitative, the intake, if it is more than 80
More than
grams,
80 grams for
more than 80 years, so you can consider him to have taking a significant amount of alcohol to produce, damage to the liver. isn't it? Now this patient is taking for the past 30 years and nearly 100 grams every day. Is he taking every day?
Yes, sir.
Yeah, that is what he has, he cannot live without alcohol, isn't it? So that is another very important definition for, alcoholism or alcoholic. So that is another very important thing. You should have brought this into history of presenting illness. Don't keep this into personal history, because the cause for his problem, the end-stage liver disease, is because the alcohol, isn't it? Suppose if the alcohol intake was not the reason, suppose he does not give you a history of alcohol, what is the other commonest cause nowadays which can also produce cirrhosis of liver or chronic liver disease? It is becoming more and more common nowadays.
Non-alcoholic stuff.
Yeah, non-alcoholic steatohepatitis. Invariably, patients usually will be obese patients with, metabolic syndromes will be there, and their waist margin will be very high. So usually you can know that the patient has got non-alcoholic steatohepatitis. So that is another common cause. So whenever you have a patient with history of jaundice, so you will have to rule out whether it is prehepatic, hepatic, or post-hepatic with the history. So that becomes very, very important. And another common thing is now the patient has also presented with ascites, isn't it? Now you said distension of ascites, and he was admitted to the hospital with ascites about 2 months back, and he has been diagnosed to have chronic liver disease. And if the patient is having ascites, what is the commonest cause of ascites in patients with chronic liver disease?
Portal hypertension.
Yeah, that means you are telling that the patient also has developed portal hypertension. If the patient is having portal hypertension, usually they would be giving some drugs to reduce the quantity of ascites and also to reduce the portal hypertension, isn't it? So, because you have not mentioned anything about the drug therapy in your total history, which is very, the medication history is very, very important. So, because he has been admitted to the hospital now, because he has been admitted to the hospital with history of hernia and he is being posted for surgery, you have examined him, isn't it? So he will be on drugs. And drug therapy, the medication history becomes very important. If the patient is on a particular medication, you may have to do some extra investigation for that, or whether to continue the drug on the day of surgery, or stop the drug on the day of surgery, or whether if you continue the drug on the day of surgery, what are the interactions with your anesthetic agents, isn't it? So these all the things will become very important as far as the medication history is concerned. So you should have asked what medications the patient is on now for his comorbid condition, that is a chronic liver disease. Usually what drugs the patient will be on for portal hypertension? What drug usually?
Somatostatin analogs.
Pardon?
Somatostatin analogs.
Yeah, is he on any somatostatin?
He's not on any. He's not on any medication.
What is the most common drug that is given actually?
Right.
Common drug that is used for cardiovascular
Octreotide.
No, it is beta blockers. Non-selective beta blockers are usually given for patients with portal hypertension. How do you think that non-selective beta blockers like propranolol? Invariably, the patient will be on propranolol. You have not asked properly. If you had asked, he would have told you. So how propranolol will reduce portal hypertension?
It causes plantar vasculitis.
Pardon? Very good.
It causes plantar vasculitis.
There are two methods by which it produces decrease in the portal hypertension. One is by reducing the cardiac output, directly affecting the heart. And second thing is it produces splanchnic vasoconstriction. Once the splanchnic vasoconstriction occurs, so there is decreased blood in the portal system also. So that produces a decrease in the portal blood pressure or portal hypertension will come down. So invariably the patient will be on beta blockers 1. Second thing is what drugs the patient can be on for ascites.
Diuretics.
Yeah, invariably the patients will be on diuretic. So does the patient is on diuretic?
He's not taking any medication, sir.
No, he will be on after admission at least. Since how long he has been admitted now?
He has come to the OPD, sir. So
In the OPD only.
First-
No, invariably you
2 days, sir.
ask properly, because if he has ascites, in order to reduce the amount of ascites, he will be on actually sodium.
Diuretics.
Yeah, one is sodium reduced diet, that is salt restricted diet.
Yes.
And second thing is he'll be on diuretics. Invariably, he can be on either potassium sparing diuretics and also in combination with loop diuretics. So suppose if the patient is on potassium sparing diuretics, any investigations you have to do for such patients?
Electrolytes will have to take, sir.
Yeah, what electrolyte?
Potassium level.
Yeah, potassium will be increased or decreased?
Potassium level
Pardon?
increased.
Yeah, potassium can be increased, isn't it?
Increased,
So,
sir.
yeah, increased. So, whereas if the patient is on loop diuretics,
Potassium level will be decreased, sir.
yeah, it will be decreased. So, invariably, whether the patient is on any of these diuretics, you have to get the potassium estimation done, isn't it? So, these are few of the things which are very important. So, you have to include. And another very common thing, suppose the patient has hepatic encephalopathy, which is again one of the complications of portal hypertension and also cirrhosis of liver. So, what about his sleep? What happens to the sleep?
First, there is initial disturbance of sleep, and then followed by somnolence in the grade 4 of hepatic
Isn't it? So that all those complications of
encephalopathy.
end-stage
Grade 4
liver
is coma.
disease, yeah, you should try to bring them into history of presenting illness only. Another very common problem with end-stage liver disease, what happens to the hemopoietic system? We will go into details afterwards, but just I wanted to ask.
Due to he'll have thrombocytopenia, hypersplenism.
No,
Erythropoietin production will be less.
more important than all these things, what about the coagulation profile or coagulation factors?
Vitamin K
will be there, sir.
prothrombin will be elevated for these patients.
So there will be
Iron will also be
coagulation factors, production will
Deficiency.
be a problem. There won't be
Vitamin K
vitamin K deficiency. Vitamin K deficiency will be there in obstructive jaundice. We'll come to that later. So here coagulation factors are not, synthesized because the liver is very important for the production of coagulation factors. So with that, if the patient is more prone for bleeding dialysis. And in your history, you have not asked anything about bleeding dialysis, isn't it? You should always, how do you ask for bleeding dialysis? What questions you will be asking?
history, bleeding, any bruises,
Gum bleeding.
One is bruises, okay.
gum bleeding.
Yeah, gum bleeding, very good. Then
Melena, in case
melena,
of encephalitis.
yeah, very good. Then
Uh,
hematuria,
hemorrhage.
isn't it? So these are simple questions. You should always no. You should now you should note down all these things when you are presenting a liver disease patient or chronic liver disease patient. These are the very important things that has to be presented in the history. Okay. So now we'll go to the examination findings and then we will discuss how to manage these patients. Just read about the examination. We'll also discuss about your examination findings.
General examination. Patient was examined in well-lit room in broad daylight after taking compressant. Patient is conscious, cooperative, well-oriented to time, place, and person. Thin built and malnourished. Height 165 centimeter, weight of 70 kgs. BMI 26.6, 26.2 kg per meter square. Pallor absent, icterus present in sclera, no clubbing, cyanosis, lymphadenopathy, and edema. No signs of liver cell failure, alopecia, lateral madarosis, parotid swelling, gynecomastia, palmar erythema, xanthelasma, Dupuytren's contracture, fetal hepaticus, spironady, and asterixis. And umbilicus is everted. Next slide. Vitals, pulse rate 75 beats per minute measured in the right radial artery, regular, normal volume and character, no radioradial, no radiofemoral delay, no vessel wall thickening, BP of 127 per 76 millimeters of mercury in the right arm in sitting position, respiratory rate of 16 per minute, abdominal thoracic type, and saturation of 98% in room air, and patient is afebrile. Next. Next slide. Airway examination, neck movements.
Normal, you just say it is normal airway.
Yes, sir.
Yeah, okay.
Next slide. A systemic examination, perabdominal examination, inspection, a distended abdomen, umbilicus central and everted, all quadrants move equally with the respiration, no visible pulsation or peristalsis, no scars, no signs, and no prominent veins. Right inguinal swelling extending above groin crease down into scrotum up to the upper pole of the right testis. Single pyriform shaped swelling of size 10 into 4 centimeter. Skin over swelling is normal and cough impulse present. Penis is in midline. Left inguinal region is normal. Next slide. Palpation, no local rise of temperature, or tenderness overlying the swelling. Right inguinal swelling extending above groin crease down into scrotum up to upper pole of right testis. Single pyriform shaped swelling of size 10 into 4 centimeters, swelling above and medial to the pubic tubercle surface, extends into the scrotum. Was able to get above the swelling. Consistency is doughy and granular. Abdominal girth measured at the level of umbilicus is 104 centimeter. Liver palpable 4 centimeter below right subcostal margin. Regular border, firm in consistency. Moves with respiration and no splenomegaly. Next slide. Percussion, liver dullness noted in the right fifth intercostal space till 5 centimeter below the intercostal space. Shifting dullness is present. Next. Systemic examination, on auscultation, normal vowel sounds heard, no bruit or venous hum over the mass, no enlargement of left supraclavicular lymph nodes. Respiratory system, bilateral air entry present, normal vesicular breath sounds heard in all areas, no added sounds. Cardiovascular system, S1, S2, heart sounds present, no murmurs. Central nervous system, higher mental functions normal and no focal neurological deficit. Summary, 60-year-old male, known case of decompensated liver disease with no signs of liver cell failure and a chronic alcoholic, came with complaints of right inguinal swelling, reducible in nature, and abdominal distension, is planned to undergo plasty.
Okay, so Mahal, you can stop. Yeah, okay. Now, again, your general physical examination. So, few points I just want to ask you because you have written about icterus present in sclera. That's all you have written.
Yeah.
So, should you grade the icterus? How do you grade the icterus? What is mild icterus? What is moderate? What is severe icterus? You are not graded there. You have just written
To the
jaundice is present. That's all.
yes.
So it's mild, moderate, or severe icterus. How do you differentiate? What is mild?
Okay, like when the icterus is present even in the palms, soles, yellowish discoloration present even in the
How do you
palms,
grade?
soles.
I'm asking you. That's okay. How do you grade it? If it is a very pale yellow scleral discoloration, very pale yellow scleral discoloration, mucous membranes are not discolored, skin is not discolored, it's a mild jaundice, or you can say icterus plus 1 plus. So if the sclera is
Yes, sir.
almost the mucous membrane of the tongue and then the hard palate is yellowish discoloration is there, it is moderate, but skin is not yet, yellowish discoloration is not there. But if also skin is also discolored, yellowish discoloration is there, then you call it as, severe jaundice. So mild, moderate, severe. So 1 plus 2 plus 3 plus. So it's very important when you are examining. If it's not just, jaundice present is not enough. So you'll have to say whether it's mild jaundice, moderate, and severe. When do you have usually the mild, as far as, for example, let us say it is a prehepatic, hepatic, and posthepatic jaundice. 3 different types of jaundice we have, classified, isn't it? In our history only when we were discussing. What happens to the, the grading of jaundice in prehepatic jaundice? Is it mild, moderate, or severe?
Moderate. Mild to moderate jaundice.
Very mild. It is very pale yellow discoloration. Lemon yellow, mild discoloration. That too, if you examine in the patient in broad daylight, then only you can differentiate. Otherwise, you may not be able to differentiate this at all. It's a very mild jaundice. So that is what usually in prehepatic, whether it is because of the congenital hemolytic anemias or it can be because of absorption of a thrombus anywhere in the body because of injuries. So it produces grade 1 icterus, very pale icterus. When do you have severe icterus?
Obstructive jaundice.
In obstructive jaundice, very severe jaundice can be there. Even the bilirubin can be as high as 35 milligrams per deciliter in obstructive jaundice. So there, even the skin will be colored, in the mucous membranes are colored, not only the sclera. Sclera can be orange, yellow, deep yellow to orange. So that is one thing I have observed in your history. So you should always mention that.
Yes, sir.
The second important thing about is the clubbing. So in which kind of liver disorders clubbing can be there?
Probably.
In which
Liver?
kind of clubbing can be there?
End-stage liver failure.
End-stage liver disease. Okay. Anywhere else? In biliary cirrhosis. Biliary cirrhosis. So clubbing invariably can be there.
Yes, sir.
So another very important thing here is, you have written patient is thin built and malnourished, you have written. But his BMI is 26.2. He is in the overweight thing as far as body mass index is concerned. Isn't it? When do you say based on body mass index, he is poorly nourished and
Less than 18, sir.
less than 18, isn't it? Now,
Yes,
yeah,
sir.
why did you write down as 26.2 body mass index as poorly nourished?
So, he appeared to be very thin built, so just due to
Yeah,
arthritis.
naturally, all these patients with cirrhosis or end-stage liver disease will have, their limbs will be very thin unless they have edema all over. Otherwise, they'll have a huge ascites. And the weight actually is increased because of the fluid in the abdomen, because they are ascites. So that is what you should have. When I asked the question, you should have come out with that particular answer, isn't it? That is, that he is very thinly built and, poorly nourished, but actually his weight must be because of the ascites that is present. So that is another thing. And one more thing is you have written about the saturation as 98% at room air. So what position did you check this saturation? Is it in the lying down posture or in the sitting posture?
Upright
And what
position.
is it? Pardon?
Upright position, in the sitting position.
The sitting position you checked. Now, why it is important whether to check in the sitting position or down posture?
Hepatopulmonary syndrome.
Hepatopulmonary syndrome, what happens in HPS?
Patient will have less oxygen content saturation because of increased vasodilators in the pulmonary
What problem he can have?
vasodilation.
What problem it is called as?
PAO. Platypnea,
One is
orthodoxia.
orthodeoxia. Is
Yes.
platypnea and orthodeoxia. What do you mean by platypnea and what do you mean by orthodeoxia?
Platypnea is a patient is having dyspnea in supine position and it is dyspnea is present in the upright position and it is relieved in the supine position.
Yeah, it is decreased, not relieved, decreased in lying down.
In orthodox,
Unlike a cardiac patient and pulmonary disease patients, they'll have more dyspnea in the lying down, that is orthopnea. And in sitting, they have some amount of decrease or they even get relief. Whereas in chronic liver disease patients, they have what is called as orthodeoxia and platypnea. Platypnea is when they sit, they have dyspnea. When they lie down, they have some amount of relief of dyspnea. We'll discuss that when we discuss about all the pathophysiological changes in chronic liver disease. And what is this orthodeoxia? Why the saturation? How much saturation fall will occur once they sit?
more than 5
Yeah, more than
percentage
5%
after sitting for more
saturation.
than 10 minutes.
Yeah, more than 5% of saturation decrease will occur once they take an upright position, isn't it? So what you should have done?
We have to measure both in supine and also in the upright.
Yeah, but in upright posture itself, it is 98%. You need not have to worry. That means he doesn't have, obviously may not have hepatopulmonary syndrome. So that you should always remember to get the saturation taken in lying down posture and then make the patient to sit, wait for about 5 minutes and again check for the saturation. Also observe whether the patient becomes more dyspneic in sitting posture because of platypnea. Okay. So another very important thing is how do you look for ascites? In your examination only, I just noted few of the things. So I just wanted to ask you a few things, questions. How do you check for ascites? What are the tests you do? One test you have done, shifting dullness. So how do you do the
Shifting dullness,
How do you perform? How do you perform shifting dullness?
you have to make the patient lie in supine position. You have to start percussing from the xiphiscus.
They have to abduct their
Pardon?
hips, sir. They have to abduct their hip and lie in the supine position, sir.
Okay.
So then we have to percuss
From the midline.
You have to percuss from the xiphisanum till the umbilicus, till the rest of the note is heard, and from the umbilicus you have to go near the either right or left axillary margins, and till the dullness is heard. And when the dullness is heard, we have to ask the patient to turn to the other side, and we have to with the hand resting over there, and on percussion, rest of the note is heard. This means the fluid which is present in the dependent region has shifted to the other dependent region.
Very good. So that is shifting dullness, isn't it? Yes. So that usually in major amount of accumulation of fluid, like massive ascites, you will find this test to be present, and in this patient it is present. That means he has got a bit of ascites is there.
Yes.
And what is another test that is done for this kind of massive ascites?
Fluid thrill.
Pardon?
Fluid thrill can be done, sir.
Fluid thrill that you have not done. I don't know whether you have not written there. So what is this fluid thrill? How do you perform?
You have to make the patient lie in supine position with hips abducted. You have to place a cardboard or a patient's hand in the midline near the umbilicus, and on tapping on the one side of the abdomen, you have to palpate in the other below the costal margin. On tapping on transmission of the thrill will be heard on the other side. Felt. Yes, sir.
Felt. Okay. Why do you want to keep his hand in the midline?
So obstruction, transmission.
So it doesn't the thrill doesn't get transferred through the skin, but other than via the fluid. Sir.
Correct. Only it should be transmitted through the fluid, the skin directly. That's the reason. So these are invariably they'll ask you in the exam. How do you check for? Suppose if it is a mild amount of fluid, how
Yes,
do you check? Small
Vital
amount.
sign.
Yeah, what is this? How do you check for?
To make the patient in a
Lie
dog
on all
position, lie on all four limbs with knees flexed and on resting on the arms. And on when the patient is having very little ascites, the fluid will get accumulated near the umbilicus and on
percussion, you can feel the
pressing.
dilute.
Okay, that is very important.
Okay.
Small amount of fluid. So these are the tests, because these two tests you have not, and you need not have to do this particular test if there is a massive ascites, but fluid thrill you have to elicit. So that is one. Second thing is, how will be the surface of the liver in patients with cirrhosis?
Hard and nodular
Nodular,
surface.
isn't it? Because you have not commented on the surface of the liver. Should always
Yes,
comment
yes, sir.
on the surface of the liver, because it will be nodular. And what will be the consistency of the liver? Is it soft? Is it cystic? Is it firm? Is it hard? I think we have lost the connection, or what?
Sir, I think their network is slow, sir.
Yeah, that is what I'm not able to. They have become a still. No, because that is very important when we are having these discussions on Zoom, so that,
Yes, sir.
you should have a good connection, internet connection. Otherwise, these problems will be there. I don't know whether they heard my question or not.
I'll just get back to them, sir.
Yeah. Just call them and then see.
Sure, sir.
Yeah, they're back. What happened?
There was a network issue, sir.
Network issues
It
should
got
not
cut.
occur, actually. So anyway, I was asking you about the surface of the skin, surface of the liver should always comment on that, whether it is nodular or smooth surface.
Yes,
And consistency, I was asking you.
Yes, sir.
What was the consistency? You have not written about the consistency of the liver. Is it soft, hard, or cystic, or firm?
It should be
Now, what will be the consistency in case of
nodular consistency, sir.
firm and consistent.
cirrhosis?
Cirrhosis will have
Cirrhosis nodular.
hard and consistent.
No, it will be firm. It will be firm. In malignancy, it can be hard. Malignancy. In cirrhosis, it will be firm. Otherwise, it is soft. Normally, it is soft. Okay, so another, that is important thing. And in the respiratory system, what else? Sorry, in abdomen again, splenomegaly is very important. If you should properly palpate for the spleen, because if there is ascites is there, it's palpable. There is portal hypertension is there. Patient has been diagnosed with chronic liver disease. So invariably the spleen would be enlarged because of the back pressure effects of the portal hypertension,
Yes, sir.
isn't it? So you said that you have written that liver is not palpable. So if you have to properly, palpate for the spleen, so then only you say whether spleen is palpable or not. Okay, so that is another very important thing which I observed. So what else you can examine in the respiratory system? What else can be present whenever there is pulmonary, portal hypertension? For examination, what else can be there? These patients can also have hydrothorax, pleural effusions. Hydrothorax can be there. Yes, hydrothorax can, the fluid through the foramen in the diaphragm, the fluid can enter into the thoracic cavity and can produce hydrothorax. That is one thing. And sometimes
Yes, sir.
because of decreased amount of albumin, so they may develop low effusions also. So
Yes,
these things we should always, we should try to examine the patients for. Okay, let us briefly, now we have written that this patient is posted for hernia.
Yes.
Before that, you can be asked some of the questions on the anatomy and physiology of the liver itself.
Yes, sir.
So normally, what is the weight of the liver?
1.5 kg, sir.
Yeah, 1.5 kgs. It's one of the largest organs in the body, isn't it? So the second important thing is what is the blood supply, amount of blood supply to the liver?
it has dual blood supply from both
Now, how
hepatic.
much first total amount of blood flow? Then we
25% of cardiac.
Pardon?
25% of cardiac output.
25% of the cardiac output, roughly 1200 to 1500 ml of blood per minute will be there. And you were telling that it has got a dual blood supply. What is the dual blood supply for?
75% from the hepatic artery and 25% from the portal.
I hope you have mistaken for that.
Yeah.
75% from
Yes, sir.
portal vein or hepatic artery?
Portal vein.
Portal vein.
Yeah, 25% from the hepatic.
25% from hepatic artery.
75% from the portal vein, isn't it? So this, what about the amount of oxygen the liver will be getting? How much from the hepatic artery and how much from the portal vein?
From portal vein, 50 to 60%, sir. And from a hepatic artery is 30 to 40%, sir.
It is 50-50.
Yes.
Because, what will be the saturation of the hepatic artery blood and what will be the saturation of portal venous blood? Portal venous blood, what will be the saturation? It's a venous blood.
Yes, sir. Yeah.
What will be the saturation of venous blood?
40%.
Pardon?
40%.
No. Saturation of venous blood. What will be the saturation? It is 75%, isn't it?
Yes.
Venous blood saturation is always,
Yes, sir.
SpO2 is always 75%. Arterial blood?
95%, sir.
Yeah, hepatic artery nearly you can say 100%, isn't it? So
Yes,
that
sir.
though the hepatic arterial blood supply is only 25%, but the amount of oxygen the liver will be getting is nearly 50% of oxygen from hepatic artery, though the blood supply is only 25%.
Yes, sir.
And whereas from portal vein, it is nearly 75%. Portal vein is made of what veins? What veins will drain into
Superior mesenteric vein and splenic vein.
Yeah, splenic vein. Why should you know that superior mesenteric vein and splenic veins, they drain into the portal vein?
So when there is a portal hypertension, we know that the backflow of the blood will be.
Back pressure effects.
Yes, the back pressure.
Yeah, what back pressure effects will be there on which particular areas?
Splenic condition can
Yes,
occur
and what happens to the spleen?
Splenomegaly will
Splenomegaly. That
Yes,
is
sir.
why I was asking you
check for the spleen.
as portal hypertension, then definitely there will be splenomegaly.
Yes.
So that is because of the back pressure, because splenic vein has to drain into portal vein. And
Yes,
if there
sir.
is a high pressure in the portal venous system, so back pressure affects splenomegaly automatically will occur.
Yes, sir.
That is why it's very important to know how this portal vein is formed from superior mesenteric and portal splenic veins. Okay, that is one thing. And how this blood flow to the liver is regulated? What is extrinsic regulation? What is intrinsic regulation? No, don't think that these questions will not be asked for you in the practicals. Any question can be asked for you in the practicals.
Yes.
Because the liver blood flow is very, very important, because all our anesthetics can have an effect on liver blood flow. Any decreased liver blood flow can affect the postoperative liver functions. So that is why you should know about the regulation of blood supply to the liver. What is extrinsic factors which regulate the liver blood flow?
Cardiac output, sir.
Very good. Cardiac output. Second,
Uh,
the perfusion pressures,
yes.
isn't it? The perfusion pressures that depends on the blood pressure. So cardiac output and the perfusion pressure, indirectly the blood pressure are very important for the regulation of blood flow to the liver. So that is extrinsic factors. What are the intrinsic factors? Have you heard about autoregulation?
Yes, sir.
All organs, they'll have an
Yeah.
autoregulation as far as blood flow is concerned, whether it's brain, liver, kidney, whatever it may be, isn't it? So one is the intrinsic regulation is by autoregulation. What is the other one? What is HABR?
So,
It is HABR. It is hepatic arterial buffer response.
yes,
Now, these are commonly asked questions in the practicals in the exam.
sir.
These two are very important. Okay. What about the autoregulation?
Uh,
Will it be there all the time, autoregulation, or when it will be there actually, autoregulation for the liver, the amount of blood flow? One thing you should realize, autoregulation will be there only in fed patients. Means in fed, then only the autoregulation of liver blood flow will work.
Okay.
And when they are not, when they are fasting, autoregulation will not work.
Mm.
Majority of our patients who come for anesthesia and surgery,
Will be fasting.
they are fed patients or fasted patients.
Fasted patients.
Fasted patients. So your autoregulation will not work. So
Yes,
your
sir.
intrinsic factors are very important. The other one is HABR. So what is this hepatic arterial buffer response?
Uh,
Can you elaborate on the hepatic arterial buffer response? What is this? Will there be any compensation from the hepatic artery whenever there is a decreased blood flow from the portal venous side?
yes, sir. Once the portal vein blood flow has reduced, so hepatic artery will compensate for the portal vein, sir.
Hepatic artery will increase its blood flow.
Yes, sir. Increase its blood flow.
By whenever there is a decrease in the blood flow through the portal vein, the hepatic artery will
The
come.
portal vein blood flow. Yes.
How this occurs? What is the mechanism? No, if you know, you say yes, or otherwise I'll explain to you. There is no problem at all.
Sure about it.
Pardon?
So not sure about the mechanisms.
Okay, you're not sure. What happens, you know that the liver is made of lobules, isn't it? So millions of lobules. That is a basic structure of a liver. The liver lobules are the functional structure is unit is called as an acinus. So the liver lobule, peripherally it has the portal venule, and also it has the hepatic arteriole, and also a biliary canaliculi, and also it has lymphatic also. All these will be in the periphery. And both the blood from the portal vein and the hepatic artery will drain into sinusoids.
Yes, yes.
So that is, the sinusoids are formed in between the rows of hepatocytes. There is a rows of hepatocytes, radially distributed hepatocytes. So in between the hepatocytes, you have the sinusoids. So both hepatic arterial blood and the portal venous blood will drain there, isn't it? And then it will start giving oxygen to the hepatocytes, and finally it will enter into the central vein, which is present in the center of the lobule. So this is the basic structure of a lobule. So normally, routinely, what happens there are a lot of vasodilatory substances are produced by these hepatocytes. If the portal venous blood is enough, these vasodilators which are produced there are flushed fast, rapidly into the central vein. Suppose if the portal venous blood decreases, these vasodilators will remain there, get accumulated, they produce dilatation of the hepatic arterioles. So that the blood flow into the hepatic arteriole will increase and the blood flow from the hepatic arteriole into the sinusoids will increase. And this is what is called as hepatic arterial buffer response. So whenever there is a decrease in portal venous blood, so it is buffered by the hepatic arteriole. So how much maximum it can buffer?
Yes, sir.
How much maximum decrease in the portal venous blood can be buffered by the hepatic arteries?
Twice the amount it can buffer, sir.
Maximum is 50%. Whenever there is maximum reduction of 50% will be compensated of portal venous blood will be compensated by the hepatic artery. If the blood flow from the portal venous system is decreased further, it will not be able to compensate. So there is a threshold for hepatic arterial buffer response. And why it is important for you to know hepatic arterial buffer response as an anesthesiologist? Why should you know?
Because of
Do you think any of our drugs have got an effect on suppressing the hepatic arterial buffer response?
yes, sir.
What drugs will suppress the hepatic arterial buffer response? Pardon? No. It's only halothane. Among all
Halothane.
it is halothane which suppresses the hepatic arterial buffer response.
Yes, sir.
The other inhalation anesthetic agents like sevoflurane, desflurane, or isoflurane do not suppress the hepatic arterial buffer response at
Yes,
one
sir.
mag. That you should always know. That is why halothane is not an ideal agent to be used in patients with liver disorder, isn't it? So what are the other problems with halothane? Why you should not use halothane? One is it suppresses the hepatic arterial buffer response. So blood flow automatically will be decreased. Whenever the portal venous blood flow is decreased, it will not be compensated by the hepatic artery. One problem with halothane. What are the other problems with halothane? Why we should avoid halothane in patients with liver disorders?
It can cause halothane hepatitis within 3 weeks.
Another problem is halothane hepatitis, isn't it? So that you should always know. Halothane hepatitis is a common theory question also. And in practicals also, in the afternoon, halothane will be there. They'll ask you about halothane hepatitis. So
Yes, sir.
how many types of halothane hepatitis are there?
2 types. Sir.
Yeah, very good. What are those?
The first type is the
Type 1.
first is type 1, which
Oh.
occurs within weeks, and it is rapidly progressive. It leads to end-stage liver disease within
No.
matter of few weeks.
I'm confused.
The second one is low
So-
progressive.
Type 1 is you are confusing with acute renal failure or hepatorenal syndrome. Don't get confused with hepatorenal syndrome with halothane hepatitis. Halothane hepatitis has got 2 types. One is the mild variety, which we may not be able to find out. It is type 1. Type 2 is almost fulminant hepatitis
Yes,
with
sir.
halothane. Fulminant hepatitis. And type 1 is majority of the times it may be because of the metabolic theory. The halothane producing the metabolites, especially the anaerobic metabolism of halothane, producing metabolites which can produce liver damage, which is very, very mild, and that is type 1. Whereas immunological mediated is the one which can produce type 2, which occurs because of repeated exposures of the patient for halothane. That is type 2 of fulminant hepatitis. That is mainly because the trifluoroacetic acid, which is a metabolite of the aerobic metabolism of halothane, can produce trifluoroacetic acid, which is otherwise short form is TFA. And this TFA can act as an heptine or an antigen, provoke antigen antibody reaction, and can produce the immunological damage of the liver, and fulminant hepatitis can occur. So these halogen hepatitis, you should always remember. And who are all the patients who are prone for halogen hepatitis?
Elderly patients with
Okay, one is elderly patients, right? Who are all the other patients?
alcoholics.
Alcoholics, yes, already patients who have got liver damage, alcoholics, or any other liver disorders the patient is having.
Exactly. Any autoimmune disorder.
Immune mediated disorder.
Guessing. Okay. No, mainly, any other patients who are obese patients,
Obese.
obese female patients, very common. Smokers, because smoking will induce the hepatic enzyme systems. So that can induce the halogen hepatitis. Again, by forming more aerobic or anaerobic metabolism of halogen, because 20% of halogen gets metabolized in the liver. So one of the highest metabolism percentage as far as the inhalation anesthetic agents are concerned. Whereas isoflurane just 0.2%, sevoflurane 2%, and desflurane 0.02%. Halogen is 20%, it gets metabolized. That's why the metabolites and any further increase in the metabolism can induce hepatitis, halogen hepatitis. So smoking and other drugs like alcohol also can induce, and or ether can induce. So the other drugs which can induce or make the patient prone for halogen hepatitis are the anti-epileptic agents, non-steroidal anti-inflammatory agents. So these are some of the drugs which can also potentiate the effect of halogen to produce halogen hepatitis. So invariably, the the buffer system is inhibited by halogen. So that is why another reason why we don't use. Second thing, halogen hepatitis. The third thing is, it produces quite a bit of myocardial depression, halogen. So thereby, it automatically decreases the cardiac output and decreases blood flow to the liver. So these three are the reasons: hepatic arterial buffer response suppression, halogen hepatitis, and decrease in cardiac output, decrease in blood pressure. So that is the reason why halogen is not an ideal agent to be used in patients with liver disorders. Okay, so we were discussing about the blood flow to the liver, isn't it? About the other important thing, sometimes you may be asked about the lymphatic system. How much of lymph will be produced by the liver and where it is produced in the liver? That also flows back towards the, portal triad. You must have heard about the space of Disse.
Yes,
Between
Yeah.
yes, sir.
Yeah, where it is present, space of Disse.
between the two sinusoids.
Between the sinusoid lining and the liver's hepatocyte lining, isn't it? In between, you have the space of Disse. So anatomy you should know, because anatomy is very important for you. The basic, suddenly the examiner may start asking about basics. So anatomy, physiology, and all those things. And especially liver, very important. And in the space of Disse, the lymph is formed, and then it drains into the lymphatic vessels, which is present in the portal triad, and then comes back into the system. So almost 50% of the lymph present in the body is produced by the liver. So that is another very important thing you should always know about. And when do you say the patient has developed portal hypertension?
Signs of portal hypertension.
No, when do you say based on the pressures? Hypertension means the pressure, isn't it?
Yes, sir.
Portal venous pressure of 5 to 7 is the normal portal venous pressure. Of more than 10 with clinical symptoms is diagnosed as portal hypertension.
So you always go with the pressure gradient, hepatic venous pressure gradient, isn't it?
Yes, sir.
HVPG, hepatic venous pressure gradient. If it is more than 5,
It is portal hypertension.
hypertension. It's
Normal should
severe
be
when it
40.
crosses 10. Hepatic venous pressure gradient crosses 10 millimeters of mercury. We call it as severe
Process 10.
portal
Yes, sir.
hypertension. Now,
Portal
why
hypertension.
portal hypertension occurs in cirrhosis? Why the pressures, portal venous pressures will increase?
The increased resistance will be there, sir,
Yes,
because of
very
the
good. Why
abundance of
increased resistance occurs?
there will be fibrosis occurring in the
Degenerative nodules and fibrosis interspaced in the liver causes the degradation of the normal liver architecture.
Very good.
so
So the
increases the
sinusoids architecture also is, distorted.
yes, sir.
Normally the sinusoids are so straight, they'll just, empty into the hepatic veins. Now once they get distorted, so the blood from the portal vein and the hepatic artery cannot go directly and enter into the central veins. There is a lot of an obstruction is created. And because of that, the back pressure effects will be there, isn't it? So because of that, the pressures in the portal venous system will increase, and that you call it as portal,
Portal hypertension.
isn't it? So that is very important. And now coming to the functions of the liver, we'll just discuss about functions of the liver, and then we will go into what happens to these functions once the patient has an end-stage liver disease. Can you just tell a few of the functions of the liver?
Glucose metabolism,
Yes, very good. Metabolism of carbohydrates.
Carbohydrates.
How glucose metabolism occurs in the liver?
gluconeogenesis, glycogenesis, glycogenolysis.
Okay, what are these? Can you just explain?
From galactose and
No, what is glycogeno? What is glycogenesis?
from glucagon to
No. What is glycogenesis?
Uh, so
Normally, carbohydrates are, absorbed in the form of glucose, isn't it?
yes, sir.
And
We stored as glycogen.
glucose is converted to glycogen and it is stored by the liver.
Stored in the liver.
Whenever that is after feeding, and whenever you are fasting, for example, whole night you are not taking anything, isn't it? Of course, some people do in between they wake up and then start eating also. That is different. But majority of us will not eat anything in the whole night, and many times will be fasting also. And during fasting also, you will not develop hypoglycemia, isn't it?
Yes, sir.
That is mainly because this glycogen is broken down to glucose, and this is what is called as glycogenolysis. Glycogenesis is storage of glucose in the form of glycogen and in fasting states, breaking down of this glycogen to glucose and maintaining the glucose levels is because of glycogenolysis. Okay. What is neoglucogenesis?
when the glycogen stores are exhausted,
Very good.
the hepatic glycogenolysis is used. So the substrates such as lactate.
No. Neo means what? New. Glucose is formed not from glycogen. It is formed from proteins and fat.
Fats.
That is what is called as neoglucogenesis. When carbohydrate content itself is low, patient is fasting, glycogen stores are exhausted, then it will maintain the glucose levels. That is why neoglucogenesis. So that is another very important thing as far as the functioning of the liver is concerned. So in patients with chronic liver disease, they cannot be able to maintain their glucose levels. They may suffer from hypoglycemia, especially these alcoholics. Invariably, they may come with hypoglycemia, and even hypoglycemic coma they may come with. Though they may not be taking any hypoglycemic agents, they may not be diabetic also. So this is one thing you should always. So carbohydrate metabolism, right? Other functions of the liver.
Protein metabolism.
Yeah, okay. Which
Breakdown.
one is very important as far as proteins are concerned for us as anesthesiologists? Which particular protein synthesis?
Albumin, sir.
Albumin, very good.
Albumin synthesis.
Albumin is entirely synthesized by the
Liver.
isn't it? And protein synthesis, almost nearly 50 to 150 grams of protein synthesis occur every day.
Yes, sir.
Right? And chief of this protein is albumin. What about globulin? Globulin is synthesized by the liver or not?
No. No, sir.
Globulins are not synthesized by the liver. They are mainly synthesized by the plasma cells in the reticuloendothelial system. So it is mainly the albumin. So what happens to the albumin levels in chronic liver diseases?
Chronic liver disease will reduce, sir, but in acute liver disease, it won't be much. It won't be affected.
Why in acute liver disease it will not be affected?
The
Very
half-life of albumin is 20 days, sir. So
Yeah,
it
nearly
will take
20 days.
20 days.
So you cannot diagnose acute liver disease by measuring
Albumin.
albumin levels. So it may be normal also, isn't it?
Yes.
So that is about the albumin. And again, albumin is the principal plasma protein for maintaining the oncotic pressure. So whenever albumin levels will come down, so there can be edema everywhere, isn't it? Including ascites also can occur because of the hypoalbuminemia and pleural effusions. All these things can occur. Okay. And another important thing about albumin for us, suppose if there is decreased amount of albumin, how it affects you as anesthesiologist?
Oncotic pressure, pulmonary edema. When we give anesthetic drugs, the volume of distribution also increases, and the protein binding.
If it decreases or increases, if albumin levels are
No,
less.
sir, volume of distribution increases, sir, and protein binding. Since there is less protein for it to bind, there will be a lot of
proteins also make as far as the volume of distribution, isn't it?
Yes, sir.
So now the free drug concentration
Drug will be
very high.
increased, sir.
And many of the drugs which are carried by albumin, you'll have to reduce the dose.
Yes, sir.
Like especially your thiopentone sodium, your propofol, they're all carried by albumin. Local anesthetics are carried by which protein? Is it by albumin?
No, sir. No, sir.
It is by alpha-1 acid glycoprotein.
Yes.
Local anesthetics are not carried by albumin, but by alpha-1 acid glycoprotein. Majority of your neuromuscular blocking agents are carried by
albumin.
Okay, so that is how you should be knowing about this albumin, which is one of the important synthesizing property of liver, isn't it? So, okay, what are the other
Clotting factors in clotting.
Pardon? It also important as far as
Clotting factors
the
in
fat is concerned.
fat
Metabolism, isn't it? Especially degradation of fat, lipolysis, formation of cholesterol formation is basically by the liver itself, isn't it? And then producing lipolysis and also acetyl coenzyme A for Krebs citric acid cycle, all these things so it is involved in fat metabolism. So all three, carbohydrate metabolism, then and fat metabolism. And another thing you are talking about, the coagulation factors. You just mentioned, I think.
Yes, sir.
What are all the coagulation factors which are not synthesized by the liver?
Factor 8 and 3 is not.
1 milligram factor and factor 8.
What about 3? Factor
3 is also, yes, sir. 3 is also not.
3, calcium.
Yes, sir.
Not synthesized by the liver. 3, 4, and 8, and 1 Willebrand factor. These are the 4 coagulation factors which are not synthesized by the liver. Other coagulation factors are synthesized by the liver. So that is why. So, and again in them, we have vitamin K dependent coagulation factors. So can you name these coagulation factors? Vitamin K dependent coagulation factors.
2, 7, 2, 5, 7, 9, 10. 2, 7, 9, 10.
Yeah, 2, 7, 9, and 10. They are vitamin K dependent. Why they are vitamin K dependent?
Only with vitamin K only activation of these clotting factors happens in the presence of
Vitamin K.
Vitamin K.
Very good. So what sort of an activation they require? Gamma carboxylation
Gamma
of these
carboxylation.
procoagulants to make them active coagulation factors. So vitamin K is responsible for gamma carboxylation. So vitamin K presence is very, very important. So what happens for coagulation profile in patients with chronic liver disease?
Prothrombin time would be
Yes,
increased.
so INR can be,
Increased.
prothrombin time can be increased, INR can be increased. And what about
Yes.
in obstructive jaundice? There also INR will be increased?
No, sir. There the clotting factors are produced, so the coagulation profile will be at the normal limits.
Normal, is it? Vitamin